Hi everyone, thank you very much for inviting me to this meeting to talk about vaccines and their effect on multiple sclerosis risk and DMT. A lot of people, I am very disappointing not to being with you in London, but we have to cope nowadays with the pandemic situation. So regarding this talk, I don't have any disclosure. As you are well aware, the therapeutic arsenal for MS has grown considerably, and many new disease-modifying treatments are available. In this context, a lot of questions arose on the safety of vaccines due to the public ambivalence about immunization in multiple sclerosis, on the effectiveness of vaccines in patients exposed to disease-modifying treatment, on the prevention of potential infectious risk induced by this treatment, and on the most adapted application of the vaccination schedule for the optimal immunogenicity. So, as you know too, there is a problem with the vaccine confidence, especially in Europe. And you have here on the slide on the right-hand side a picture of the vaccine confidence about a survey conducted in 2019, and you can see that a lot of European countries and a lot of people are very suspicious of the vaccines, especially in Europe. There is increased fear of vaccine-related side effects rather than fears of the disease itself. And you have here a screenshot of the MSologist and French neurologist taking a picture of themselves being vaccinated against COVID-19. And this has a lot of success, and we think that the seemingly most effective way to increase vaccination rates among our patients is with clinician recommendation. So here are the recommendations and guidelines available worldwide. You have these from the American Academy of Neurology, from the French MS Society, and from the Spanish and Italian Society. The majority of MS-based recommendations are similar in context when compared to other autoimmune diseases, for example, rheumatologic diseases. And in France, the French authorities consider MS patients treated with anti-CD20 or S1P modulators as our priority for COVID vaccine. We will present at the next ECTRIMS in Late Breaking News the European recommendation for vaccines in MS in cooperation with the European Academy of Neurology, and we were inspired by the French, the Spanish, and the Italian recommendation. So the first question about vaccines in MS is safety. And the first question among safety is, are vaccines associated with an increased risk of MS? And the answer regarding the literature available is no. Vaccines in general are not associated with an increased risk of MS or occurrence of a first demyelinating episode of the central nervous system, including for hepatitis B and human papillomavirus vaccines. The second question is, are vaccines associated with an increased risk of relapse in MS or of worsening of disability? And the answer again is no. Vaccines in general are not associated with an increased risk of relapse in patients with MS. An increased risk of relapse after vaccination against yellow fever cannot be excluded. This recommendation has been written in 2019, and since then, a new paper in Multiple Sclerosis Journal, first author Caroline Papex, has been published demonstrating that in MS, and specifically in relapsing remitting patients, there are no increased risk of relapse or worsening of the disease after yellow fever vaccination. Influenza and BCG vaccines have no impact on short-term accumulation of disability. impact of other vaccines on disability has not been studied yet. So to summarize, standard immunization protocols are not contributing towards greater MS risk and higher disease activity. So the conclusion on safety are the perceived ambivalence regarding vaccination in MS should be toned down, as the literature contains today enough evidences demonstrating safety of immunization programs. Vaccination should be early considered as in the algorithm of MS management to minimize risks. In untreated MS patients, the benefit of most vaccines greatly outweigh any potential risk. And last but not least, inactivated vaccines can be safely used in MS patients receiving any DMTs. The question 2 is about immunogenicity. Are vaccines as effective in people with MS as in general population? In treated MS patients should be capable of mounting an immune response to antigenic stimulation similar to those who do not have MS. Immunosuppressive DMT effect may modulate the effectiveness of vaccines by lowering the capability of the immune system to mount an effective response. Available data on the efficacy of inactivated vaccines in patients with MS and without disease-modifying treatment suggests that it's similar to the general population, particularly for mono and trivalent influenza vaccines. No studies are available yet for live attenuated vaccines. So are vaccines as effective in people with MS exposed to DMTs? It depends. Levels of protection need to be compared with healthy subjects and/or untreated MS patients. Not all vaccine has been tested with every DMTs available, and some gave evaluation of persistent protective hemagglutination titers, but no comparison of infected patients. So if we look at the injectables, beta-interferon and glatiramer acetate, the response of vaccines is not decreased. There is a doubt with glatiramer acetate that some responses might be decreased. So for dimethyl fumarate, the response of vaccine is comparable to beta-interferon. Chronic lymphopenia and deep chronic lymphopenia, stage 3 or stage 4, should recommend to apply advices for immunosuppressive drugs. For the teriflunomide, responses of vaccines is decreased compared to interferon beta. And regarding immunosuppressive drugs, it depends on the mode of action and on lymphopenia. Decreased levels of protection compared with healthy subject and/or untreated MS patient should recommend to apply what we are using for immunocompromised patient. For natalizumab, the response of vaccines is reduced compared to healthy control, as well with fingolimod, and compared to healthy control, untreated patient, and interferon beta-1b and beta-1e. For ocrelizumab, the response of vaccine is reduced compared to untreated patient and interferon beta. And we should consider the timing of vaccination regarding the time of the infusion. For mitoxantrone, response of vaccine is clearly reduced compared to healthy control. And for alemtuzumab and cladribine, there is insufficient data. There was 2 studies published during the last months which demonstrate that there was not a great problem with cladribine, but it has to be confirmed. Conclusions on immunogenicity: the timing of vaccination should be adjusted to optimize vaccine responses, given the potential interference of disease-modifying drugs on the achieved immunogenicity. Immunosuppressed patients should not receive live vaccine, either viral or bacterial, due to the potential risk of developing vaccine-related infection. And recommended vaccines are those of the vaccination schedule for the general population and vaccines specifically recommended for immunocompromised patients, specifically influenza, pneumococcus, and COVID-19. So in daily practice, what prevention methods should be offered to patients with MS? Standard vaccination programs need to be applied, whatever the country the patient is living in. We have to follow the WHO guidelines, which may vary and which are based on the local prevalence of tuberculosis specifically, and yearly influenza vaccination in MS patients on immunosuppressive treatment. Patients treated with immunosuppressive drugs have lower responsiveness to vaccines in general and have to be informed by each individual prescribing the DMTs. And just to focus on steroid treatment, live vaccines are contraindicated. No vaccine within 1 month of high-dose corticosteroids. Here are 3 useful tools you can use in your clinical practice. The first one is the vaccine scheduler. It's very easy and free. You enter the country you are living in or your country you want to be traveling in, and you have all the mandatory vaccines depending on the treatment and on the disease. And you also have the application of the French MS Society, which is fully available in English. And you have an assistant of prescription depending on the age of the patient, the historic of the DMT or the treatment you would like to start. And you have all the recommendations you should apply for the vaccination schedule. So here are some recommendations for SARS-CoV-2 vaccines. In fact, I will not detail this slide because we will have another talk about COVID-19 just after this one. But just one short remark, the teriflunomide and anti-S1P modulator have possibly antiviral properties, but it can also increase infection. And we should be very cautious about the impact of each treatment on possible acute respiratory syndrome, because some patients might be more at risk to develop severe form of the infection, specifically anti-CD20, rituximab, ocrelizumab, ofatumumab, antimetabolites such as methotrexate, azathioprine, mycophenolate mofetil, and the Bruton tyrosine kinase inhibitor. So yes, the COVID vaccines are working for our patients, and in a lot of countries right now, we recommend having a 3rd dose of a COVID-19 vaccine for specific DMTs, specifically anti-CD20, anti-metabolites, and fingolimod. So if we want to summarize the schedule of immunization in clinical practice, on the left-hand side you have the different drugs and then what you can apply for scheduling the vaccination in your patient. So if the patient has or disease related, if he is not treated or if he has injectable treatment or natalizumab, you don't need any adjustment, whether initiating or already on this DMT. If the patient is treated with S1P modulator, dimethyl fumarate, teriflunomide, azathioprine, mycophenolate, mitoxantrone, and cyclophosphamide, when possible, you should advise to complete vaccination schedule 4 weeks before starting this DMT. And if the patient already taking this DMT, then you don't have any adjustment to make. If the patient will start anti-CD20, so rituximab, ocrelizumab, or ofatumumab, here is the same recommendation. When possible, complete all the vaccination schedule 4 weeks before starting this DMT, and consider started vaccine injection at least 12 weeks after the infusion if the treatment is already ongoing. or for ofatumumab just prior the next injection. And last but not least, for alemtuzumab and cladribine, if you are not able to perform all the vaccination scheduled before starting the treatment, then the vaccine injection at least should be performed 12 weeks after the treatment and avoid resuming DMT until 4 weeks. So here are some thoughts to share. Inactivated vaccines are safe for our MS patient and related disorders. We have to double-check mandatory vaccine schedule before starting any DMT and to recommend vaccines early before any treatment if possible. There is no restriction for vaccines with immunomodulators and specifically injectables. We should apply the recommendation for immunosuppressed patients for second-line disease-modifying treatment. We will recommend vaccination for relatives if the patient have contraindication for the full vaccination schedule. The timing of vaccination should be adjusted to optimize vaccine response, and we should suggest scheduling, but it's not always possible, so getting the vaccine may be more important than the timing of the vaccine with DMT. And of course, we should recommend strongly anti-COVID-19 vaccines. So thank you again for your attention. You have all these recommendations on the French MS Society in French and in English. And we have some recommendation about COVID-19 on the MSFIF website. And we will present the European recommendation at the next extremes in late breaking news. Thank you very much for your attention.